All right, let's talk about sepsis at Brockton Hospital. So um, let's start with the fluids. Um, Sepsis fluid resuscitation. In severe sepsis, the patient presents with severe sepsis, which we know it's about. It's serous criteria, two serous criteria, plus a source of infection, plus hypotension or organ dysfunction. When that is presented, it's an emergency, and that time is actually determined to be a medical emergency. Within 30 minutes, we are allowing people 30 minutes. It should not be 30 minutes, but we're allowing people 30 minutes to get their stuff together, to review the chart, talk to the family, to do all of these things and get the fluids ready. But within 30 minutes, the first drop of fluid resuscitation should start. Within 60 minutes of that, the first 2 liters are finished. It's has been shown that the faster you give the first bolus of fluid, the better. For the longest time, we've been doing only 2 liters, but with more emphasis on 30 mLs per kilo, which end up almost always becoming more than 2 liters, then we really cannot. We would love to be able to give the first all of the 30 mLs per kilo in the first hour, but we can't. So we continue to do what we used to do, which is over 60 minutes, we give 2 liters of fluid. Whatever is left after that, let's say 2.5 liters is the number, then the next half liter is giving within the next 60 minutes. So in total, the maximum amount of hours that you can give the 30 mLs per kilo at Brockton Hospital is 2.5 hours. That's actually less than the Medicare or CMS recommended guidelines and also the surviving sepsis guidelines, which is 3 hours. It gives us a half hour of buffer. The remainder, that's the end of it. If the patient then responded to the fluids, that's the gray zone. If the patient responded to the fluid and now the blood pressure is normal, which is SBP above 90 or MEP above 65, at the end of that resuscitation, then we have to continue 250 cc's an hour for 10 hours because the fluids will come out of the circulation. Or, depending on the patient's condition, we can place a central line and titrate fluid accordingly for the first 10 hours. That's if the patient responded to the fluids, and this is just the maintenance. That gives him another 2.5 liters. In septic shock patients, if the patient actually progressed, received the initial resuscitation, but the blood pressure did not respond, the patient is placed on pressors and is actually considered septic shock, and that's another medical emergencies. The bell is rung, and we have our own door to balloon, if you will, or door to ICU time, which is 60 minutes. The central line has to be placed also within 60 minutes of diagnosis of septic shock. Fluid resuscitation, we give the maximum of the pump, which is 999, 1,000 cc's an hour, every hour until the CVP reaches 12. There's no procrastination here. We're not going to give 100 cc's an hour, 150 cc's. It's an urgency of now. If you don't resuscitate the organs will fail. If you don't resuscitate the kidney will have acute kidney injury. If you don't resuscitate the lung will have acute lung injury, with or without the fluid. So the patient has to get 1,000 cc's an hour until the CVP is 12. So it is guided by the CVP. It's not just 1,000 cc's an hour, just like that. So until the CVP reaches 12 or 16 in intubated patients, and that's according to the guidelines from the Surviving Sepsis Campaign. After 6 hours of that, of the intensive early goal-directed therapy, if the blood pressure is still low, then we have a period of time within 4 hours of that we have to place a cardiac output monitor and monitor using A-line and LIDCO or SWAN, and follow the shock algorithm, which will follow in the next slide. That is to acknowledge that the CVP is not actually accurate, but it's a quick initial resuscitation goal. In cases of surgical patients, at the end of initial resuscitation, the agreement with the surgical team is that we would do, regardless of the response, after that initial resuscitation, the 30 mLs per kilo, everybody gets that when they do severe sepsis, when they become severe sepsis. For surgical patients, we just jump to this last box here, which basically, regardless of the response, whether they improve with the fluid or they go on pressors, it doesn't matter. We're going to put a cardiac output monitor that's an A-line analytical or a SWAN and follow the shock algorithm to be more specific. This is the shock algorithm. We can discuss it in another time, but it all depends on the cardiac output and the stroke volume, and follows a very rigorous algorithm that we have here at Brockton. There's always a consternation about how much fluid to give and how fast to give the fluid. This is the question of the ages. People have been asking this question all along, and I don't think people like the answer, whatever they get from the Society of Critical Care Medicine. This comes from Medscape, and you can look it up online. And this is extracted from other original articles that we can provide. If the hypotension doesn't respond to crystalloid fluid bolus 30 mLs per kilo, 1 to 2 liters over the 30 to 60 minutes. Here is telling us that we have to supply to give the crystalloids over 30, that's 30 mLs per kilo. We have to give it over 30 to 60 minutes. In fact, it actually regulates it for you and say 1 liter over the first 30 minutes, 2 liters over the next 60 minutes, which is exactly what we do here at Brockton. And basically, that will tell you right away that the hypotension is not responding to fluid. In fact, the Colorado Hospital Association mentions that we have to give the fluid the first liter over 15 minutes. The first liter over 15 minutes. And here they give you a quick. This is all from the Colorado Hospital Association guidelines, from extracted from the Surviving Sepsis campaign. They talk about how fast the fluid is being given. They recommend 1,000 cc over 15 minutes, or if you want to do it, in aliquots, you can do 500 cc every 15 minutes until the 30 mLs per kilo is reached. And here it does show that, see how concerned they are about the rapidity of the fluid resuscitation. The recommendation is to provide initial fluid resuscitation rapidly. Do not infuse using IV pump. They say that. That's exactly what we do at Brockton Hospital. For example, give 1 liter of IV fluids over 15 minutes using a pressure bag. Over 15 minutes, 1 liter. More rapid fluid administration and greater amounts of fluid may be needed in patients with sepsis-induced tissue hypoperfusion, and administration of 30 mL per kilo crystalloids is still recommended in patients with end-stage renal disease, dialysis, or chronic heart failure, with frequent assessments of the patient respiratory status. And that's the analogy that I always use, is that it's a can of soda. It's less than a can of soda. 1 liter of normal saline is equal less than a can of soda that you're giving the patient. So don't be afraid of giving this amount of fluid. This fluid is not going to end up in the circulation at the end, and the patient needs the fluid for resuscitation. They also continue to debunk or ask or answer the questions that is being asked. Why do all severe sepsis patients need volume? Vascular volume is lost into the interstitial space due to diffuse capillary leak. Both venous and arterial tone is reduced, and the blood volume occupies a larger intravascular space than normal. This is all well-known physiology, and many of those patients have GI and skin losses. So these septic patients do require a huge amount of volume. And of course, they try to debunk this barrier, which we're going to flood the patient. And, as we all know, this hasn't panned to be true. The barrier has been debunked because if you look at the early goal-directed therapy, for the hours after resuscitation, it actually shows that when you do the stand, that's in Emmanuel Rivers' article or study, it shows here that the standard therapy, which is not giving the fluid that the early goal-directed therapy recommends, which is adopted by the Surviving Sepsis Campaign, the standard therapy at 72 hours, many patients have actually reached to the same amount of fluid that was given initially from the early goal-directed therapy. So giving the fluid early will prevent you from giving fluids later. Antibiotics and early fluid resuscitation. These are articles here that show that the association of fluid resuscitation in the initial within 30 minutes of sepsis and severe sepsis and septic shock, and the recognition actually resulted in mortality with later fluid resuscitation. In fact, administration, the mortality was 13% if you administered the fluid within 30 minutes. If you administered within 31 to 60 minutes, the mortality increased to 16%, 61 minutes to 180 minutes. That actually mortality is the same, 16.9%. And if you administer the fluid after 180 minutes, the mortality increases to 19%. This is an amazing study that was done there. Also, there is another study that is a retrospective review, and they found that it's also a retrospective review, and after adjusting for co-founder, the higher the proportion of total fluid received within the first 3 hours were associated with decreased hospital mortality. And another study that actually showed it's a multi-center trial looking at the treatment bundle, and they found decrease in hospital mortality was observed primarily in patients with heart or kidney failure who received at least 2 liters of fluid resuscitation with severe sepsis and lactate in between 2 and 3. This is an important message for people who think that these patients, because they are sick, they should not receive the fluids, especially renal failure, CHF. There's always consternation about those, and this study actually debunks these or alleviate these fears. This is another study that showed that early fluid initiation within 30 to 120 minutes was associated with significantly lower hospital mortality and mechanical ventilation, ICU admission, and length of stay and ICU days. No harm was observed. That's in less than 2 hours. The 30 mL per kilo to be given in less than 2 hours. Of course, over the years, I've heard this myth all the time. Everybody's scared, and we have to, it became so good at alleviating these fears in people. And I collected these four X-rays for 4 different patients, and you can see that the X-rays did not change. The problem that we think of the lung as it's only a conduit. It's not a conduit only. The lung is a huge organ that has a lot of tissues. If you take the cartilages out and bunch the 2 lungs together, they're equal to the size or more than a kidney. It has a lot of cells that does hormonal function, does capillary leak prevention, and also does a lot of other functions in the body, lymphatic and stuff. So if you don't perfuse the kidneys will develop acute kidney injury. If you don't perfuse the lungs will develop acute lung injury. So if you don't give the fluid, the lung will develop acute lung injury. This is a 95-year-old patient who had a pneumonia, and he received 5 liters in 1 day with no BiPAP. It was impossible to put him on BiPAP, and that's his X-ray after. It actually improved, not worsened, with 5 liters of fluid. This is a 73-year-old patient who received 5 liters in 1 day with BiPAP. It worsened a little bit probably, but not too much. This is a 79-year-old patient who received 8 liters in 2 days with BiPAP, his pneumonia, and this is improved. And this is a 60-year-old patient who received 14 liters of fluid in 3 days. It was a surgical patient. Actually, this is with an endotracheal tube. So this patient here, and that's his post resuscitation with the 14 liters in 3 days. And as you can see, the X-ray is the same. This is a publication by Mitchell Levy, none other than Mitchell Levy, who actually reviewed and made a new changes in the surviving sepsis campaign, and they have an hour 1 bundle, an hour 3 bundle, an hour 6 bundle, and in the hour 1 bundle, the recommendation is to give the fluid as fast as possible, rapidly administer 30 ml per kilo crystalloids. That's a strong recommendation and strong quality of evidence, and again, the rapid administration of fluid, and that's 30 ml per kilo, and that's all within the hour 1 bundle. As a result of very rigorous understanding of the physiology and very rigorous teamwork at Brockton, you can see that that these mortality rates here represent, Brockton Hospital represent the lowest in 2018, lower than any reported mortality rate in the world. Of course, we didn't report it, or didn't report it yet, but for severe sepsis and septic shock, we were extremely low in 2018, which made us actually made us try to go on a campaign to improve mortality to even 10%. And this is our rigorous sepsis 1 based septic shock protocol, and this is our mortality. These two columns here at the end, you can't see the legend here, but they are 2020 and the national average. So this is in 2011. We have data before that, but only for septic shock. These data here for severe sepsis and septic shock, mortality rate was 22%, went down to 18, went down to 15, 15, 14. Right here in 2016, we did a campaign when we found that this is the data that we're having. We did a campaign to improve mortality from severe sepsis and septic shock, and we can see some improvement there. In 2019, we did another campaign to improve mortality, and we can see from the campaign started in April, and you can see beginning from May 2019 till February 2020, the mortality rate actually in these 10 months are pleasantly surprisingly 12%. So we were on a right track to go down. We didn't achieve the 10% that we wanted, but we were on the right track to achieve the 10%. And what ended up happening is that we got hit with COVID. So starting in March 2020, we got COVID, and during the year of 2020, because of COVID mortality, our mortality went up to 23%. Despite all of that, despite being during COVID and the severe mortalities that we've seen during COVID, we still did not hit the national average of mortality from severe sepsis and septic shock, which is 28% in a good day. So I think we have still a lot to do, and still a lot to improve. And coming back from COVID, we feel like kind of losing balance a little bit, and everybody has to go back to where we were before. I think if this trend continues, I think we're going to achieve the 10% that we want. And thank you.